Hello, welcome to Bogomolets National Medical University, Department of Propedeutics of Internal Medicine. We continue our lecture course, and today's lecture is devoted to the auscultation of the heart, heart sounds in norm and pathology, organic and functional heart murmurs. I am VictoriaKhomazjuk, Associate Professor of this department, and let's begin our lecture. First of all, you need to remind anatomy and physiology to understand auscultation. And I hope that you know that there are 4 valves: mitral, tricuspid, aortic, and pulmonic. This is the cross-section, a longitudinal cross-section of the heart, where we can see mitral valve, or we can see tricuspid valve, we can see also semilunar aortic valve, and pulmonary trunk is here, but we don't see the valve in this section. Well, you should also know the cardiac cycle. It consists from systole and diastole. Look at the picture. On this picture, we see that atrioventricular valves are closed and aortic and pulmonic valves are opened and blood goes to the vessels. So this part of cardiac cycle is systole, and here we see, of course, diastole, when the blood from the atria, right and left, comes into the ventricles. Wow. So what happens in the systole? Let's in short remind. The ventricles contract, raise the pressure, and the pressure is higher in ventricles than in atria, so mitral and tricuspid valves close. And this gives us the first heart sound. Pressure continues to rise. Aortic and pulmonic valves open because the pressure in the ventricle becomes higher than in the vessels, and the blood is injected into the arteries. So all these contribute also to the first heart sound. Then the pressure in the ventricles begin to fall. And at the moment when the pressure in the ventricles is less than in the vessels, aortic and pulmonic valves close, and at this moment we can hear second heart sound. And at this moment also the diastole begins. When the aortic and pulmonic valves closed, at the same time mitral and tricuspid valves were closed at the beginning of the diastole, but after some time they open because the pressure in the atria becomes higher than in the ventricles. Then the blood moves from atria to ventricles, and the walls of the ventricles vibrate, and this gives us the third heart sound, or it is called S3. Then at the end of the diastole, the atria contract, and this contraction and emptying of the atria give us this fourth heart sound. It is due to vibration of the walls of atria and ventricles when the blood is going due to atrial contraction. And then cycle repeats itself, and you should note that cycle is slightly slower on right side of heart. So the first heart sound is produced by valve component muscular component, vascular component, and atrial component. These vibrations caused by atrial systole in norm are blended with S1, but in pathology they may cause the fourth heart sound. Second heart sound is generated by two components. There is valve component and there is vascular component of the second heart sound. The abbreviation for it is S2. Oh well, so sounds third and fourth, S3 and S4, are muscular. They are generated by the vibration of mainly ventricular myocardium. Here we see a picture with projections of the heart valves to the anterior wall. Yeah, and we see that these projections are very close to each other. But when we auscultate, we use areas and points for auscultation, which are shifted aside, so we can better differentiate which valve we are auscultated at the exact moment. So this is usual order of auscultation of the heart. First of all, we begin from auscultation of mitral valve at the heart apex. And then we auscultate tricuspid valve at the base of xiphoid process. The next will be aortic valve in the second intercostal space to the right of the sternum. And then will be pulmonic valve in the second intercostal space to the left of the sternum. And the fifth, or so-called Botkin-Erb point, will be to the left of the sternum in the third intercostal space. It may be much more points for auscultation, but when we begin to study propaedetics of internal medicine, we ask you to remember these main 5 points or areas of auscultation. So here at the picture we can see once more that projections of the heart valves are here. And then let's remind the points of auscultation. First one is at the apex of the heart. This is apex of the heart in the 5th left intercostal space. Medially from the mid-clavicular line. So this is for mitral valve. Then next point will be here at the base of xiphoid process, but it is not drawn on this picture. Then next point of auscultation will be for aortic valve in the second right intercostal space. Next point will be in the second left intercostal space, and here we auscultate for pulmonic valve. And the last point, Botkin point, in the third left intercostal space. We see here one more additional point, but at least you need to know the 5 main points. You should understand that you should auscultate the patient in different positions. First of all, you auscultate the patient in supine position, and we see here that stethoscope is put at the apex of the heart, so we auscultate for the mitral valve. And look which part of the stethoscope the doctor uses. So we see the diaphragm is upwards, but to the skin the doctor presses the part without diaphragm, which is called the bell of stethoscope. It is used for auscultation of the low pitch sounds. Next variant, you may ask your patient to turn to the left side. In this position, the heart will be closer to the chest wall, and you may better hear some sounds. One more position will be of the patient will be upright position. In this position, for example, you can better hear the sounds from aortic valve and pulmonary artery sometimes. Well, so this is the order how to interpret the results of auscultation of the heart. In each point of auscultation, you should analyze what you are hearing according to this order. First of all, you should assess rate and rhythm. If the sounds, heart sounds, are regular or not. So if your patient has arrhythmia. Next, your conclusion should be how many sounds, 2 or more, do you hear? Because at least 2 sounds, S1 and S2, are audible in all points, but maybe 3 or 4 heart sounds. Well, then you need to differentiate which sound is first, which is second. Then you should analyze, maybe you are hearing some splitting of the sounds and extra hard sounds. And then you will compare intensity of S1 and S2, and according to this, you can make a conclusion about increase or decrease of these sounds. First heart sound, S1, you will estimate in the points of mitral and tricuspid areas because this sound is originated due to the work of these valves. And to assess S2, you will use aortic and pulmonic areas. Well, so normal heart sounds. This is the instruction how to differentiate normal heart sounds and how to decide which one is first and which one is second. The golden standard for this is the pulse on the carotid artery. Or you may use also an apex impulse, but it is not always palpable. So the pulse on the carotid artery will coincide with the first heart sound. The sound that you hear at the moment of pulsation will be S1. Another variant will be to distinguish sounds is to assess the pause between the sounds. Look, this is normal cardiac cycle. So S1 is usually heard after long pause. The pause between S1 and S2 will be short. But this technique works only if the patient has no tachycardia or arrhythmia. In case of arrhythmia, you will use carotid pulse. You can't use intensity of the sounds to differentiate them. Of course, we know that S1 is louder at the apex, for example, and S2 will be louder over aorta and pulmonary artery. But you don't know that your patient, the person that you examine has normal sounds. They may be decreased or increased due to pathology, so you can't use the intensity of the sounds to differentiate them. You need to first differentiate the sounds and then only you will check their intensity. Oh well. So what findings we may what may be findings during auscultation? It may be normal heart sound, S1 or S2. You may find splitting, and S3 and S4 are not always heard. They may be only in pathology. And you may hear extra heart sounds, which form so-called triple rhythms, such as gallops. Also, we can hear mitral snaps, ejection clicks, and friction rubs. What is splitting or reduplication of the heart sounds? It means that instead of one sound, you can hear two short sounds very quickly follow each other. And this may be the result of asynchronous work of the left and right ventricles, or left and right chambers of the heart. This is the picture to show you physiologic splitting of S2. It is connected to breathing. You can see here that during expiration we see only two sounds, S1 and S2. But during inspiration we hear S1, but S2 is from two short sounds due to closure of aortic valve and pulmonic valve. We can see this splitting if the pause is more than 0.02 seconds. This is explanation of physiological splitting of S2. Oh wow, S3, as you remember from our excursion over the cardiac cycle, is caused by the vibration of the ventricles when they are filling in diastole. That's why S3 is more close to S2. And when you auscultate the heart, you hear S1, S2, and after a very short pause after S2, you hear additional S3 sound. The pause may be from 0.13 to 0.20 seconds from the beginning of S2. S4 is heard, on the contrary, in the end of the diastole. So it is very close before S1. We said before that in normal subject we can't differentiate S4 by auscultation. It will be the part or atrial component of S1. But in pathology we can hear it separately, so it will be very close before S1. How will we find S1? We will use the pulse on the carotid artery, and only S1 will coincide with this pulse. Next, we will review in short triple rhythms. Different triple rhythms. First of all, it may be gallop rhythms, because they are resembling galloping of a horse. They may be protodiastolic at the beginning of diastole. It consists of S1, S2, and S3, pathologic S3. Then it may be mesodiastolic. We hear additional sound in the middle of diastole, and it is due to S3 and S4, which are heard as one sound, because such gallop mainly occurs on tachycardia. And the last variant, we have presystolic gallop. It consists of S1, which is diminished, normal S2, and increased S4. So all three sounds will be of the same intensity. Well, so this is protodiastolic gallop once more, decreased S1, S2, and S3. Well, and you remember this S3 appears after 0.12 to 0.20 seconds after S2. Well, presystolic gallop, and summation of mesodiastolic gallop, which consists of S4, S1, S2, and S3. But on tachycardia, the pause, this diastolic pause, is so short that these two components are heard as one sound. You can't distinguish them without phonocardiogram. This is phonocardiogram to explain you additional sounds. To analyze phonocardiogram, we need simultaneously recorded lead of ECG. And how can we find the first hard sound, S1? It will be under complex QRS. The upper line, it's normal phonocardiogram, so we have first hard sound under QRS. The second hard sound from two components, aortic and pulmonary, is at the end of T wave. After short period, we see third hard sound. We see that it is very small, so its intensity will be very low. That's why we can't hear it by auscultation. And we have four hard sound. How we can distinguish it? It is after the end of P wave, because he appears after atrial and due to atrial contraction. And we see that the first hard sound is longer and higher than the second. This is phonocardiogram at the apex. Well, the second line, we see that fourth hard sound is increased. And it is maybe the same as the S1 and S2. But third hard sound is very small. So we have for S4, S1 and S2 of the same intensity, and this will be pre-systolic gallop. And the last line, we see that S4 is small, it's normal. S1 and S2 is of the same intensity, of the same height, and the third hard sound is also increased, and its amplitude is maybe the same as S2. So we have melody from S1, S2, and S3 of the same amplitude, and it will be gallop, of course, and the name of this gallop will be proto-diastolic gallop. Well, here is the table of different additional sounds that we can auscultate in different pathology. There are gallops here, there are splitting of the sound, and you should understand that additional sound may appear not only in diastole but also in systole. Here we see mid-systolic click, it is between S1 and S2. This sound may be heard, for example, in the mitral valve prolapse. Well, one more triple rhythm that you should know is called, it's specific for the patient with mitral stenosis, and additional sound that you will hear in this rhythm is called opening snap. It is opening snap of the mitral valve, or opening sound of the mitral valve, because in mitral stenosis it is thickened and the opening of the cusps gives specific sound. That's why triple rhythm consists from increased first sound, second sound, and opening snap of the mitral valve. This melody is specific only for mitral stenosis. Here we can see the phonocardiogram that was recorded at the apex. Of course, they are not normal, and here we see something in systole between S1 and S2, or here something in diastole, which is called heart murmur. But let's analyze the sounds first. We have ECG, and under QRS, here will be first sound, here will be second sound. This is opening snap, it's very small, and we have increased third sound. So it means that we see here proto-diastolic gallop. And we see some murmur between first and second sound, so this murmur will be systolic. Let's think. We record all this over the apex. The apex is the point for auscultation of the mitral valve. Remind the cardiac cycle. In systole, mitral valve should be closed. But we see on the recording that there is murmur. What does it mean? It means that our patient has mitral regurgitation or mitral insufficiency. And at the last line here, we see the phonocardiogram of the patient with mitral stenosis. We see, what can we see? We see increased first sound, then splitted second sound, and we see the opening snap, very intensive opening snap, and after opening of the mitral valve, the murmur in diastole begins. As we will describe the shape of this murmur, it will be increasing first, it is called crescendo, and then it will be decreasing, it is called decrescendo, and once more it will be increasing in the direction of the first sound. This is specific shape which is for the mitral stenosis murmur in diastole. And here we see murmur in systole, and the shape of this murmur is the same. It is called plateau murmur. Oh, well, once more we shall look at the auscultation order. So we do all this, we differentiate between sounds, we speak about splitting, and what else we shall do? We shall check intensity of the sounds, S1 and S2. Oh, well, so the intensity of the heart sounds may depend on extracardiac causes. It may be sickness of the wall, lung emphysema, obesity, and so on. It may also depend on some changes in myocardium and contractility. In this case, both sounds of the heart will react. But more interesting for us is to check intensity of the sounds separately if one of them is changed. Intensity of S1 diminishes at the apex. So at the apex we hear that S1 is less than S2. Do you remember that in norm S1 should be louder than S2 at this point, but we hear that it is not louder or even smaller. It may be in such causes. Next, if intensity of S1 diminishes at the base of xiphoid process, it will be the other causes which are connected to the tricuspid valve, pulmonary valve, or right ventricle. Intensity of S1 may increase at the heart apex, not much causes for this, it's mainly in mitral stenosis, you see the explanation, or it may be during extrasystole. Oh, well, okay, S2 is louder than S1 at the heart base or over aorta and pulmonary artery. Yeah? And in norm, second sound is of the same intensity in both these points over aorta and pulmonary artery. But it may be diminished in some of these points. It may be diminished over aorta. If over aorta you hear that S1 is louder than S2, you conclude that second sound is diminished. And here are the causes of such condition, possible causes. They are connected to aortic valve and the pressure in aorta. And if we hear the same melody over pulmonary trunk, the causes may be different. They will connect with changes of pulmonary valve or the pressure in the pulmonary circulation. How to differentiate increase of the S2? It is called accent of S2, and we compare this intensity of S2 over aorta and pulmonary trunk. In the point where S2 is more intensive, it means that it is increased, and mostly it is due to difference in pressure. If the pressure is elevated in aorta, arterial hypertension, it will be accent of S2 over aorta. In pulmonary hypertension, it will be accent of S2 over pulmonary artery. Well, you see this once more, yeah, with such abbreviation, maybe it will be more understandable for you. Well, in auscultation of the heart, we also check the heart murmurs. This is after distinguishing the sounds, we check heart murmurs. What should we know about murmurs? You see such characteristics of them. First of all, we check timing. When the murmur appears, it may be systolic, diastolic, or continuous in both phases. Then we check the shape of murmur. Do you remember the picture? The murmur may be crescendo, it grows. It may be decrescendo, maybe crescendo, decrescendo, or plateau. And then location of the maximum intensity murmur is very important. In which area you hear the murmur, so you may conclude which valve is affected. Once more the picture of murmurs. We see murmur, systolic murmur here, diastolic murmur. Oh, well. Radiation of the murmur may be heard not in one point. It may be radiated in the direction of blood flow that causes the murmur. We also should check intensity of the murmur, and there is specific 6-point scale, 6 grades of the intensity of the murmur. If the murmur is palpable, so you feel vibration while palpation of the chest, it is called thrill. Thrill is specific term to describe palpable vibration of the chest due to blood flow inside of the heart. We also check pitch of the murmur. It will be maybe high, medium, or low, and then it may resemble blowing. It may be harsh, it may be rumbling, or even musical in case of affection of chorda tendineae. It may be different variation with respiration. Murmurs over tricuspid valve increase when you take deep breaths and hold. And then maybe a variation with the position of the patient. Do you remember? It may be supine position, upright position, or position on the left side. And then it may be also used special maneuvers like sitting, standing, or Valsalva maneuver. So you need to, when you analyze the auscultation, you need to decide when do you hear murmur, in systole or diastole, in which point it is loudest, and this will give you the diagnosis of the valve lesion. So the murmur, if you hear murmur, of course it is the main sign of the valve disease. Here are examples of systolic murmurs and diastolic murmurs, more often heard over the heart area. Here we see the picture of different murmurs, and you see that, for example, in mitral regurgitation, you can hear systolic murmur. This is S1, and this one is S2. Look, here we see mitral stenosis scheme, S1, S2, opening snap, and diastolic murmur. The most common kind of heart murmur are mid-systolic injection murmurs. They may be functional or innocent. It means physiologic. What does it mean? It means that there is no valve disease in our patient, but we hear murmur. And they will be maybe organic or pathologic. In this case, the patient has valve disease and some cardiovascular structural abnormalities, such as stenosis or insufficiency of the valve. To differentiate functional murmurs from organic murmurs, you should use all these suggestions and maneuvers. Please read attentively on your own what should you do to differentiate the murmurs. Why it is important. Functional murmurs should not be treated, but organic murmurs is the sign of the valvular disease, and such patients should be treated even surgically. Well, and one more murmur that you need to differentiate is pericardial friction rub. This is so-called extracardiac murmur. We need to differentiate it from the intracardiac murmurs. And there are some differences in these sounds which are outlined on this slide. The continuation, let's look. This is the second part, how to differentiate. First of all, you have some maneuvers. You may press more stethoscope. You may ask your patient to hold his breath. In this case, then you may check where is the maximum point of auscultation of this murmur. And the last moment in our lecture, I should remind you about auscultation of the vessels. First of all, it may be carotid and subclavian arteries. We can hear two sounds like over the heart, over these arteries. And you see the list of arteries which may be auscultated. If the additional sound is heard over the artery, the name of this sound is brute. If we hear such sound over the heart, it is called murmur. So if you use the term murmur, it means that it is over the heart. If you use the term brute, it means that it is over artery. This is auscultation of the carotid artery. This is auscultation of the temporal artery. And here we see auscultation of the jugular vein. There are no sounds over the vein in norm, but in anemia, for example, we can hear blowing or humming sound. It is not called murmur, it is called hum or venous hum. So you see we have different terms. Murmur over the heart, brute over the artery, and hum over the veins. And if the murmur over the heart is palpable, it is called thrill. This is short lecture, short knowledge about auscultation, and I hope that you will use it in your practice to improve your practical skills. Thank you for attention.